Okay, it's very smooth surface. And then you get to also evaluate. Under normal circumstance, some sip of water could help clear some of the reverberation artifacts we are seeing here. But that's okay. So by going all the way, fanning right and left, slowly and gradually, and using your depth, regulating your depth to make sure that you are visualizing the entire liver, would help you exclude any focal lesion in this region of the liver.
Do you examine every segment in the liver, or do you go just all through?
All through.
All through.
All through.
I mean, do you check every segment of the liver? There are, for example, like segment 5 and 6, you have to examine in a different way?
Yeah, so in this plane, this is station 2. In station 2, you can see segment 5 to 8. So you are going step by step, so you are making sure that you have excluded any focal lesions in this station before you move on to the next station. So from what we have evaluated so far, we can see his caudate lobe, which is being separated from the left lobe by the ligamentum venosum, which we are seeing here. So from all indication, even if he happens to have a focal lesion, that lesion is not in the left lobe or the caudate lobe. And that means that we can move on to the next station, which is station 3.
Where is it? What is this major vessel here?
Okay, so the major vessels here, this one is the IVC.
Yes.
Which lies directly posterior to the caudate lobe.
Doppler. Can you put the Doppler here?
Okay, good.
Yes. Oh.
So that is the IVC. Let's increase the gain. What is it? What is the scale? Yeah. Okay. Gain. Okay. So good.
Okay.
So in terms of the use of color Doppler, you may have to combine gain settings and scale settings. Some machines will call it PRF, or pulse repetition frequency. If the pulse repetition frequency is lower, it increases flow sensitivity. So, and that one is something you can consider. You can also use the gain, increase the gain settings.
Yes, thank you.
This one is bringing us a lot of noise because of anyway, let me just take it off for now. So that's the IVC, and then tilting slightly to the right, to the left, you get into the aorta, which is what you are seeing here. So just a slight tilt between right and left fanning to visualize these key structures. You can see how the IVC leads directly into the right atrium of the heart. So now I am going to move to station 3, which is here.
So are we going to see the right lobe now?
Yes, so now I'm going to see the large lobe now in station 3. Now when I come to station 3,
subcostal approach.
Yes, with a subcostal approach.
Yes.
With a station 3, it's going to be a subcostal approach, beginning right from the region, but you may have to do some sliding from this xiphoid process level down to be able to see it entirely. And don't forget to use a gel for enough gel for firmer contact with the skin.
Yes, this is important. This is a good point.
And you might also need to ask the patient to take a deep breath in or push the tummy out to enable you to visualize the structures. And at this level, good.
Yes, having deep breath.
Deep breath now, we are beginning to see.
Which segments do we examine now?
At this level, we can see this right from segments
Yeah.
4 to 8. You can see the middle hepatic vein. The structure I just showed you is the middle hepatic vein. Let me quickly take a deep breath in. Okay, relax now. It's okay. So now we are seeing the middle hepatic vein here. Now all structures on the other side of the middle hepatic vein are superior structures from segments 5 to 8, and the structures at the other side towards the left of the middle hepatic vein are segments 1 to 4. So now, at this level, when you look closely, there appears to be a hypoechoic change or isoechoic change in this region, okay, above the right hepatic vein, which is this structure.
Yes.
Now, this region is the segment 7.
Yes.
And so it means that he has a focal lesion in segment 7,
Yeah.
which is what I am pointing to right here.
How would you comment over this lesion? Do you see it like well defined or just ill defined for you?
Good. So this lesion apparently is well defined. It is isoechoic.
It's difficult.
Very difficult, really.
Difficult.
I don't know how
yeah.
you see it.
You are very expert that you got it.
Yeah.
Because
yeah.
when we have an isoechoic lesion, it's difficult to discriminate
Yes.
or to differentiate between this lesion and the rest of the liver tissue.
Yeah.
And
Yeah. That's-
How big it is?
Yeah. So I'm going to measure the size of the lesion in segment 7.
Yeah.
You can use the depth and you can use the zoom to make it larger if you want.
Okay.
Okay. Okay. I may not even need it.
This is a non-cirrhotic patient, yes?
Yeah. So we have excluded cirrhosis, and then we can see the focal lesion. At least I've seen one for now. I haven't done check the entire liver yet, but at least I can see one focal lesion here, which I would measure from here to here. So I'm getting something around 2.5 by 1.8 cm in the segment 7.
Okay. If you don't have a history of malignancy in such a patient, and this is a normal liver, and this is looks like most probably for us, what would you suggest? It's most probably towards malignancy or benign.
Well, that would be a difficult one.
I know, it's a very difficult one, but it's just we have to sometimes to conclude, okay, I'm in this part, or I have to go to the next level.
Yeah.
Yes.
I think that the underlying history will be very relevant.
Yeah.
And if the person has a history of primary malignancy elsewhere, then metastatic lesion becomes one of the differentials
Of course.
to consider.
Of course. And I think Doppler might have a positive impact in differentiating primary from metastatic liver.
Yeah.
The high vascular supply of the tumor
Yeah.
with liver cancer, with primary liver cancer, versus the metastatic with a low vascularity, which is clear by the Doppler application, I think.
Okay. So now we are going to put on color Doppler.
Yeah.
We'll put color on.
Yeah.
At this point, you may have to try to use a smaller width of the color box to avoid interferences.
So now we have no vascularity in this focal lesion.
Take a deep breath, please. Deep breath.
The location is difficult.
Yes.
It
Very
is-
difficult.
It's
It's
very
So,
difficult,
small,
yes.
it's-
apparently, it is difficult to identify flow, so we may call it avascular. I think this is when maybe the superb vascular imaging that you spoke about becomes probably useful in being so sure about
Yeah.
the presence of a lesion or otherwise.
So we have discovered a single focal lesion so far now.
So far, I've seen one focal lesion.
One focal
I
lesion.
haven't, scanned the entire liver yet. So I'm going to ask him to take a deep breath again.
والنفس جامد.
And then I'll keep on sweeping
Yes.
through.
This is outside the liver.
Now I
It's-
am looking closely at segments 8, 5, 6,
Great.
and don't forget the fanning movement up and down as you go through. And so far, I haven't come across
تامر.
any additional lesion other than the one found in segment 7.
So now you are screening every single segment in the liver, and especially the subcapsular areas, and yes, in the right lobe, beside the vessels, vasculatures, the gallbladder, and according to the distribution of hepatic veins. Yes.
Yeah. So now I'm done with the station 3 assessment, which has so far identified one focal lesion from my assessment. And so I am going to go ahead to do station 4 evaluation. And that is when I'll bring it to this level. Over here, you can assess the span of the liver and the kidney. And then you can go intercostal spaces. Take a deep breath. Space by space. And then at each space, you sweep or fan up and down with deep inspiration from the patient to closely and carefully evaluate the liver for any sign of focal change. At this view too, you get the opportunity to compare the portal venous wall and the hepatic venous walls to exclude other conditions like fatty liver. I can see his gallbladder. Oh, is that another gallbladder? It is, yeah. It's contracted and contains sludge. Okay. So, I'll go to the next intercostal space, which is where I am now, still of station 4, and then sweeping through gradually. I'm now in another intercostal space of station 4, and still sweeping gradually. To see if I'll visualize any additional focal lesions.
Yeah. So we started midline to evaluate the left lobe,
Yeah.
then subcostal to evaluate the right lobe, and then intercostal space by space
Yeah.
to screen all the liver segments. So how many segments, Dr. Dina, we have?
We have 8 segments.
8 segments.
8 segments.
Yes, 8 segments.
Yes.
We have to
1, 2, 3 in the left lobe, and from 4 to 8, like in the right lobe. We have 4A and 4B. You have to examine those very well.
Yes.
And every segment should examine in 2 directions, so you have to exclude any focal lesion or any infiltration in a way or another.
Good.
So far there is 1 lesion identified in segment
Yes.
7.
This is a nice case. Thank you very much, Dr. Dow. We will invite whoever would like to engage hands-on on the patients and to follow the steps of Professor Yao. Please, anyone would like to join us? It's an hand-on. Please.
It's very interesting. You have to try it
Please.
yourself
Yes. It's for free.
for free.
No extra money. No. Go on.
The average time I need to do a scanning ultrasound for a patient with liver cirrhosis, if I'm going to proceed to look for any suspicious focal lesions, such a case was not an easy one, it was an isoechoic lesion. So what's the proper time I needed to do a proper examination by ultrasound for every patient for scanning ultrasound?
This is important point and important question. What is the duration of scanning, screening the liver with ultrasound? Dr. Yao, can you answer this?
So a number of factors will determine that. The patient body habitus is a factor. Compliance of the patient is another. Remember that you may need some deep inspirations. You may need to sometimes, beyond the supine position, also include the cubitus positions. All this should be factored in. But on the average, up to 30 minutes could go a long way to evaluate the liver fully, even including evaluating Doppler pulse wave and appearances. But then you need to take your time. It varies from patient to patient. Even if it takes you up to an hour, it is worth the time.
So the average is how many?
The average, I would say 30 minutes.
How?
30 minutes.
30 minutes. 30
Yes.
minutes.
This is important.
And it depends also on the expertise.
Expertise,
Sure.
yeah,
of the
expertise is very, very important here.
So
Yes.
this please.
Yes, thank you very much. My name is Uche Ijoma from Nigeria. I've been listening. I don't know, is there any place for something like a shear wave velocity in this interrogation, this assessment?
Yes, thank you. The shear wave velocity is to evaluate the degree of fibrosis, cirrhosis. And it is not implemented to detect focal lesions or tumors of the liver. We use this shear wave with different machines to get the F score of the patients. For example, these patients, if you would like to have his real liver status, is it just normal liver or is having a degree of liver cirrhosis? At this moment, we may apply the shear wave machine to get the F score of this liver and to have a whole data about this liver of the patient. The focal lesion plus his liver status from F1, F0 to F4. And even F4, it starts from 12 kilopascal up to 75 pascal. All these are important information about the liver status of the patient. Thank you for your question.
If you allow me, Professor Ashraf, well, the shear wave is not included in the guidelines for screening or even diagnosis of HCC. However, if you apply a shear wave over a focal lesion, which is, and you find that it's higher than the wall tissue of the liver, this means that there is a more stiffness and it's more suggestive towards malignancy. That's why they use it. It's only suggestive. to use it. If you don't have like a COS to apply or just a guidance, like, however, it's not in the guidelines and it's not diagnostic.
By the way, the ultrasound, the ERCP workshop has just started on the next hall. If anyone would like to join there, myself, I don't want anyone to leave the hall. But anyway, if anyone would like to join the ERCP hall, it's the next hall.
So Ashraf, sorry,
Okay.
again, I do have another question, sir. 30 minutes examinations, that means is that the majority of us are doing suboptimal examination of the liver, definitely, by ultrasound. Do I have to think about something like a CT abdomen, triphasic CT, to be performed every year for a patient I am screening for focal lesions? He is cirrhotic and I am looking for possible focal lesions. So if I'm doing it every 3 or 6 months, just do a confirmatory CT by time and then?
Yes, it's a good question. The using of the triphasic CT or MRI, of course, it is considered as one of the recall policy after ultrasound. If you got a lesion detected by the ultrasound and you would like to verify the nature of this lesion, so we may go for triphasic CT to verify this lesion and to confirm is it hepatocellular carcinoma or otherwise. And implementing triphasic CT or MRI for screening, it's another issue. And recently, the SLD guidelines may consider triphasic CT in some instances, in some cases, to be put for high-risk patients, cirrhotic patients after resection, after treatment. We may use triphasic CT instead of ultrasonography as a screening for such patients. That's it. But again, the ultrasound is the standard, our standard of care for the screening for HCC. Of course, it is suboptimal. Yes, it is suboptimal. But it is, on the other hand, it is a cost-effective. Okay. Please, we would like to try. We are going to follow the same steps
So-
Dr. Yao started.
So you go with station 1.
Yeah. Do
So
you have
place
any
the probe at the
experience?
xiphoid process.
Yes. Dr. Yao, you can
Okay.
join from other side. Yes. It is very important to step in a logistic stepwise for not missing any part of the liver, because it's crucial to screen every segment, every details in the liver. So you have to follow a systematic way in the examination of the liver.
So can you see the pancreas? Okay, good. Okay. So you can tilt down all the way, and now you can even see the IVC and the aorta all the way down. And then you can tilt up gradually.
The pathology
Right, well.
workshop will start at 10:30 at the VIP lounge. The pathology, if anyone would like to join the pathology workshop, it will start at 10:30 at the VIP lounge.
You can evaluate the first 4 segments. And then now, you can then turn to station 1, long axis,
Yes.
same level. Then gradually fan left to right,
So this is the longitudinal section. Then-
longitudinal section.
Yeah.
Fan gradually. Check the surface of the liver in this view. Look at the caudate lobe. You can see the IVC also showing down there. Yeah. Get your patient involved. You need your patient's cooperation.
Yes. He is very cooperative. No problem.
Yeah.
So far. So this is steps is the standard of care for screening every patient's every liver for focal lesions of the liver. Stepwise, systematic way for not missing any segment of the liver.
Okay. And then now you can move to segment 3, subcostally,
Yes, subcostal approach
subcostal approach.
with deep breath of
With
the
deep
patient.
breath. Take deep breath in.
Deep breath
Okay.
will open the view. The whole liver now is very clear. The right lobe is very clear now.
Okay.
Here the heart. Yes, beautiful.
Okay. I think you've turned approval.
Yes.
Have you? Okay, good.
By the way, this is a difficult case.
This-
It is
yeah.
not it's a difficult
So,
case.
This way.
The focal lesion is small. The focal lesion is in a very,
So you see
Critical.
in this view,
yeah.
you now find the small focal lesion
Yes, yes. It's
in
now
segment
clear.
7.
It's now clear.
Okay.
The isoechoic, it is close to the right branch of the hepatic vein,
Okay.
right?
Yeah. So you can see the lesion there.
Perfect.
But don't end here. Go to station 4.
Yeah.
You come here.
Yes,
in
intercostal.
First of all, you to the level where you would visualize the liver and the kidney together.
Yes,
You can measure the span of the liver in this view. And then you can also, at this stage, move fan. And then you move to the intercostal spaces from here,
yes.
obliquely.
Oblique. Yeah.
Yes.
Parallel to the intercostal space, it's a space by space,
Space by
and-
space.
and parallel to the intercostal space. We
Get the
put,
patient to give you support with deep inspiration.
yes,
Supine position may not be enough in some patients. You may
Yeah.
need to get them to turn lateral decubitus.
yes.
Deep breath, deep breath. Okay. Step by step. Remember that the rib will always interfere with your view without deep inspiration.
To overcome this, we put the transducer inside the intercostal space
Yes.
to avoid the noise of the bone.
Yes. So practice the fanning skill that we taught you. I mean, tilt up and down with deep inspiration.
Yes.
Okay. Good.
Have you succeeded to get the focal lesion? We are going to put a score for you. Okay, got it?
Good.
Oh, great.
Good.
Yeah, under supervision of Professor Yao, yeah, of course you got it.
Good.
Okay, we can move to another
All right.
case. Thank you very much. Professor Yao, thank you so much. Great demonstration. We would like to show you another case. Dr. Dina, would you like to join us, please?
I'll follow your rules.
Difficult case for you, Dr. Yao. It was a difficult case for you.
Yeah, it
Because you are a professor in the Hajj. Dr. Yasmin, would you please introduce the next case, please?
The next case is Miss Noura, a 30 years old female patient presented with a 4 months history with epigastric and right hypochondrial pain, and on doing abdominal ultrasound discovered to have a large hepatic focal lesion, and we see with Dr. Dina how we can assess this lesion.
اتفضلي نامي على مهلك كده نامي. يا ياسمين. ممكن تقول لنا الهيستوري بتاعها؟
هي كانت انا قلت هي بس abdominal pain بس
This is a female patient. How old are you? سنها لسه 37.
30 years old.
30 years old. She's still 30 years old.
Presented with form.
Okay, she's a hypothyroidism.
تاخديش
And كنت
ما
بتشتكي
بتاخدش
من
أي
أي حاجة
حاجة.
ولا إيه السبب إنك رحتي؟ And she was complaining of epigastric pain, and by ultrasound examination,
Yes, she has a history of liver problem.
No, she didn't have any history of a liver problem or and no history of oral contraceptive pills intake.
Any history of any
She is hypothyroid on Eltroxin.
hypothyroid.
واكتمي.
That's it.
Yes.
Diabetic.
Presented with a 4 months history of epigastric and right hypochondrial pain.
Okay.
And come to our unit for assessment by evaluation for a accidentally discovered focal lesion in the liver.
Okay. So she came to you for
Evaluation
advice
of this focal lesion.
to evaluate this focal lesion. Okay.
I will say after that the CT finding, but after end of the examination to not to bias.
Yes. Dr.
So-
Dina, can you try to again? We are going to start step by step in a systematic way, and not to miss any focal lesion. I can see that it's a very big lesion, but
Okay,
we,
yeah.
but we would like to implement a system for all of us.
Okay.
How
So-
we start steps of screening the liver, step by step, every segment.
Okay.
Okay.
So first of all, you have to locate yourself. This is the left lobe, and trying your examination with the left lobe. As you can see, this is you have to check all the segments. And before that, you have to show to see if the capsule is normal, the echogenicity of the liver, the texture, if this is a cirrhotic liver or not, the vasculature or the vessels of the liver is fine. So this is
So you
first-
started the midline,
Yes,
for
we
the left
started the
lobe.
midline. Yes.
longitudinal section,
Yes.
midline to evaluate section of the left lobe.
Yes.
Okay.
Yes, exactly.
What about the surface here?
This is a very smooth surface.
Smooth surface,
Yes.
so it indicates that it is not cirrhotic liver.
It's not a cirrhotic liver.
Okay.
Yes. Second, this is normal echo texture. This is and we don't have like hyper or hypo echogenicity, and we can't also find any focal lesion as regarding the segments here. This is segment 1, 2, and 3.
دكتور ياسمين فين دكتور
So if we move to the right lobe, you can find here, this is the gallbladder here, you can see it. And then I'm still, by the way, in the midline, a longitudinal segment. I'm just moving to the right lobe. And I saw here a very large mass, hyper-echoic. I'll start to
Yes, this
identify
is-
it, but
yeah.
first I have to identify where I am and the whole picture of the liver. Again, the surface
a
of the
huge-
liver is smooth.
yes,
Yes.
huge focal lesion,
Yes.
very
the-
bright echogenic lesion, and I think it occupies most of the right lobe,
Yes.
right?
Exactly. Now I'm moving to the intercostal space to examine the right lobe. I've examined the right lobe first from the from the midline. Now I'm in the intercostal space, and as we can see it here from a different level and different axis. You can see a hyperechoic focal lesion. Yes, and
can you describe more when
yes.
when you get like the focal lesion like this? How can you evaluate during examination? How can you evaluate it during examination? What the points you have to check on this focal lesion by the ultrasound?
First, the site.
The site. Okay.
It's here. I cannot identify a single segment. However, it's involving most of the right lobe. You cannot say like segment 8, 5, or 7.
Big.
No.
Yes. It occupies most of the right lobe.
Yes.
Next.
Second, you have to identify the size of the lesion. I will freeze, and then I will move to the caliper. Start by measuring the size, longitudinal and transverse. It's like 11 by 7. You have to try the maximum size. You might measure this several times to get the best size.
It's big. It's very big, of course.
Yes, it's very big.
And then what's next?
You go to the surface
of the size.
Now you go to the surface of the lesion.
The surface of the lesion.
Yes. Okay. Whether it's smooth or it's you cannot identify the surface.
Well circumscribed.
Exactly. Or not circumscribed.
Or not.
Yes.
Okay.
And here we can say it's very well circumscribed. It's a very well circumscribed lesion.
Yes.
Then you go to the texture, the echogenicity of the focal lesion, whether it's isoechoic, same echogenicity of the liver, or hyperechoic, increased echogenicity as regards the liver, or hypo. This is a hyperechoic lesion.
So it is hyperechoic.
Yes, it is.
Yes, it's very bright, hyperechoic. So what's next?
Then
does this hyperechoic pattern, is it homogeneous or heterogeneous?
Yes, it's more or less homogeneous. You can say it's more or less homogeneous. If it's heterogeneous, it doesn't look like, it wouldn't look like that. Mm-hmm. And we don't have like areas of liquefaction or dark areas in comparison to the other part. No. We just have a very homogeneous texture of this one.
Good. So what else?
Then
the relation with major
vessels.
Surrounding and vessels. It's important. Yes, it is very important because sometimes you might have a lesion and extend